Hi, welcome to a new session of learning new concepts, new clinical scenarios. Okay, so I want you to pause the video, read all the case scenario, and then resume it, and then we'll start the discussion. So in the clinical case, so this is a surgical trauma case. Okay, so the history goes as there is a 24-year-old male, a young patient. Okay, has history of fall from height. Okay, so this is the history, which has caused injury to the right temporoparietal region. Okay, so the right temporoparietal region, and he was brought to the emergency. On inquiry, the relatives say that the patient was unconscious at the onset of the injury. Later, he woke up and then seemed normal and then became lethargic and unconscious. Okay, okay, so we have a trauma case, a young patient. Okay, with history of fall from height in the right temporoparietal region. So we have significance for everything. So this right temporoparietal region, which is the simpler term for the area which is pterion. Okay, so this pterion area which is there, which is at the meeting of all the four sutural lines. Okay, four sutural lines. Okay, this is the weakest area and is commonly injured during the trauma. Okay, and the point is below the pterion there lies middle meningeal artery, and more specifically the anterior division of middle meningeal artery. So assuming this history, the injury is most likely on the pterion area, which lies above the anterior division of the middle meningeal artery, and if the injury is there, so this is most likely to injure the anterior division of the middle meningeal artery. Okay, so next thing on the inquiry, what the typical clinical scenario which we are getting by the relatives is that the patient on the concussion or the hit, the patient was unconscious, and then later he woke up, okay, and seemed normal and then lethargic. Okay, so this is known as lucid interval. Okay, so this is known as lucid interval. So because at the site of at the onset of injury, a concussion is there which makes the patient unconscious, and then the patient wakes up, and later when the more and more blood accumulates into the cranial cavity and pushes the brain matter or the brain substance, then the patient due to this or the brain edema, he goes unconscious. Okay, so now on examination, what you see is the right eye pupil. Okay, the right eye pupil is dilated. Okay, and there is weakness in the left upper limb and lower limb, obviously. So since there is a history of injury in the right side, you will have contralateral hemiplegia which is there, and apart from that you will have the pupils on the right side are dilated, which is as a result of your oculomotor or the third nerve, cranial third nerve palsy. Okay, so this has significance. Okay, now the patient would on examination, we are trying to calculate GCS of the patient, which is always done in patients with trauma and a neurological involvement. Okay, so this patient withdraws the right limb. Obviously the left limb is hemiplegic, lower and the upper limb is hemiplegic, so the patient will respond to the right side. So the patient withdraws the right limb from pain. Okay, so this is the motor part, and this corresponds to M4. The eye opening was seen after applying pressure to the sternum. So pressure to the sternum is a painful stimulus, and after that if the eye opening is there, then it is E2, right? And he spoke incomprehensive words. Okay, so this verbal response is V2. Okay, so the GCS of the patient is E2, V2, M4, which is equal to 8. Okay, so after this an urgent NCCT was performed, okay, for investigations. Okay, so based on all these things, okay, we'll see that what the patient has. Okay, so an young patient with right temporoparietal region with a history of classical lucid interval. On examination, the right pupil is dilated, that is the side of injury, left-sided hemiplegia, contralateral hemiplegia. The GCS is E2, V2, M4, and after the initial management, the patient was sent for a non-contrast CT scan. Okay, so what this case is. So first of all, the diagnosis based on the history and examination. So the diagnosis based on history and examination is extradural hemorrhage. Okay, due to, first of all, injury to the pterion, which indirectly suggests the injury to middle meningeal artery, which is the artery involved in extradural hematoma. First thing. The other part is the presence of lucid interval, which is characteristic seen in your EDH. Okay, so these two things signify it is a mode of EDH. Okay, so the first line of management. Okay, so if you are a surgeon which is managing this patient, you see that the your Glasgow coma scale is 8. So 8 less than 8, the first your first concern should be securing of the airway. So the airway is compromised, so you should intubate this patient. You should intubate the patient and you will secure the airway up, and this should always be done after your cervical spine stabilization. If the patient on the examination, like after the proper log roll and examination of the cervical spine and the spine, if there is no cervical spine abnormality or injury, you will have to secure the airway by intubation. Okay, what do you expect from the NCCT? So on non-contrast, so the first point is the preference of doing a non-contrast CT scan is because we are the time is very important in this patient, and we want to see if there is a bleed and which type of bleed. So the best scan is NCCT in this scenario. So I've put here 3 scans, okay, of NCCT, and we'll have to see if what is the most expected scan in this patient. Okay, so in the first scan, what you see is, on the CT scan, what you see is the in the right side. Okay, so in the right side you have a lesion, okay, which is more of a concavo, more of a convex. Okay, so more of a convex or lens shaped lesion. Okay, and the second thing what you see is the bleeding is seen in the subarachnoid cisterns, okay, and the sulci. Okay, and the third lesion which is there, it is a concavo convex lesion. Okay, so a concavo convex lesion. So the first image which we see is seen in EDH. So it is an arterial bleed, okay, and it forms a lens shape. Okay, the second bleed which we see is typically known as the 5-star appearance, 5-pointed star appearance and that is seen in subarachnoid hemorrhage, as the bleed is in the sulci and the midbrain and the pontine cisterns. Okay, brain cisterns. And the third is seen in the subdural hematoma. So the bleed is venous. Okay, the cortical breaching veins are injured here, and this type of the pattern is formed. Okay, the other point is calculation of a Glasgow coma scale P score. Okay, we have calculated the GCS score, which is E2, V2, M4. What is this P component? The P component is that if both the pupils are normal, the score is 0. If one pupil is dilated, the score is 1, and if both pupils are dilated, the score is 2. So this score is deducted from this score, this general GCS score. So our patient has one dilated, that right sided dilated pupil, so the GCS-P score of this patient, GCS-P score of this patient is 8 minus 1, that is 7. Okay, next, name the artery injured in this condition is, that is most probably the anterior division of middle meningeal artery. So for your more information, you can see this, that this is the area, that is the right temporoparietal region which I was mentioning. Okay, that is the area, that is the pterion area, which is marked by yellow, and approximately below it there is middle meningeal artery, more precisely the anterior division of middle meningeal artery, and this is the image from the Gray's anatomy. Okay, so what we have learned here Okay, what we have learned here is we have learned about EDH, we have learned about lucid interval and its presentation, we have learned about Glasgow Coma Scale P score, we have learned about the management, initial management in a case of your head trauma, okay, and few NCCTs variations.